Good afternoon or morning. I don't know when it will be shown, this video. It is an honor for me to present a talk on preserving kidney function in the setting of nephrectomy, partial or total nephrectomy in patient with renal cell CA. I had given a similar talk about 4 years ago in the same setting, but since then there is a lot of new material to talk about. So I rewrote the presentation. And as you're going to see, there are a lot of new things that are very important to know. First, I don't have any conflict of interest. My goal and objective is that a participant will acquire the nephrology concept required to manage patient in the pre-post phase of tumor resection. And besides GFR, you will see that other factors, especially the renal parenchyma of the patient, the health of the viable tissue that is non-tumor, is very important in the outcome after nephrectomy. I want to also make sure that you use an algorithm that will help especially nurses and PAs in charge of those patients, since they are very complex and there are indications for when a nephrologist should get involved. And I will briefly also present what's coming down the pipeline in terms of new diagnostic tools that will affect the way we treat those patients. I don't want to make you worried about this complex slide. Just notice that we are going to look at 3 phases. One is the early pre-resection phase, what we do to condition the patient for the surgery. One is the intraoperative phase, where very many determining factors can happen that affect the outcome. Will the patient acquire renal failure or not, or progress? And then the post-op phase and later post-op phase, the long-term management of those patients who had the renal tissue removed. In the early phase, we do the usual preparation of the patient, optimize, and you can go over this. Dr. Basile has written several protocols. Many of the PAs and nurses at Moffitt are aware, but they are a little too complex to show on this slide because they are schematic approaches that contain a lot of information. But I would refer you to those who are interested, to Dr. Basile's algorithms. In the resection phase of the patients, this depends mainly on the surgeon. The nephrologist has very little input. But what one needs to focus during operation is to keep warm ischemia very short. If ever possible, try to do nephron-sparing surgery and choose for partial rather than radical nephrectomy. As we discussed in the beginning, we were here in the pre-nephrectomy phase. Now we are in the nephrectomy phase. And then we are going to look at the early, later, and more later in years effect on usually acute renal failure, progression to CKD, and eventually in some rare patient, hopefully, to end-stage renal disease. We need to realize that during the operative phase, I went to the wrong slide here, to the operative phase, we have a time course of progression of renal failure that starts around here and is conditioned by the underlying pathology of the kidney. And nephrectomy is always done on a background of a kidney that has many risk factors. The patient may have already CKD, and this is very important in this population. As you're going to see, the study showed 10 to 50% of patients with pre-existing CKD even before removing the tumor. There is diabetes, hypertension, all those risk factors that affect how you manage the patient are there, and the operation is done on this background, and the surgeon can only minimize acute injury and things like that, avoid massive blood loss, avoid warm ischemia, and so on. But then the rest depend on the patient's factors that are shown in the parenchyma of the kidney. Let's take in the early phase, when we are here, very early phase post-op. We have a patient, and a good example, who has a normal body surface area, a normal creatinine, which gives him a total GFR of 100 milliliter per minute, and the flow is distributed 50-50 to the right and left kidney. He had a radical right nephrectomy, and now, a very small tumor, by the way, and now he has chills and fever, and his serum creatinine is 2. We are in the early phase. We are asking, or you are asking, the pharmacologist to dose medication. The question is, what is his GFR? He had a GFR of 100, 50, 50. So if you take one kidney out, will his GFR be 50? Will it be more than 50, or will it be less than 50? I let you choose your answer. The real answer is on the next slide. Let's assume a patient has a GFR of 100, and now abruptly you decrease, let's say, his renal function by 75%. He goes from 100 to 25 milliliter per minute. What happens to his serum creatinine? So if his creatinine is 1, now the injury occurs, or you take out the kidney, for example, without any injury, you do a good operation, his creatinine will go up. But as you see, as the function is curtailed, in this case 75%, as the function is curtailed, the excretion of creatinine will be less than the production. That will increase the plasma creatinine. But as the plasma creatinine increases, the excretion will again match production when you come into equilibrium. So his baseline creatinine, if he had no adaptation, would be 4 milligram per ml. But the next day, it may be only 2. So it's, even though he lost 75% in this example, his creatinine underestimates. The lesson I want to show is that you cannot use the creatinine-based equation like Gold-Crocroft or MDRD and so on to assess kidney function in the acute state. Those equations only apply in the chronic state. Here I have an algorithm for you to guide you how to, what to do and when to get the nephrologist involved. So nephrology you look in a centrifugal type way, this slide. You look at risk factors, which are albuminuria, proteinuria, hypertension, and so on, and then decrease the GFR. So this is the second layer, right? And depending on those risk factors and baseline problem, you will get a nephrologist involved. In rare cases, you don't need to, but this is basically a guide for you to know when to get a nephrologist involved. Concerning GFR, I mentioned to you that you look at eGFR based on creatinine, but this is a hyperbolic distribution in a male and in a female. Male and female have different rate of production of creatinine. So a patient with a creatinine of 1, serum creatinine of 1, has usually a GFR of about 100. And as the GFR decreases, creatinine goes up. But I want to point out, because of the hyperbolic nature of this curve, you can have same creatinine in different patients. This patient has a creatinine about 1.5 or so. This one also. But this one has no renal failure, and this one has significant renal failure. Same for females. So creatinine itself is a poor marker of GFR. And obviously, when we do nephrectomies in donor kidneys, those patients have been selected for absence of proteinuria, absence of hypertension, absence of diabetes. All those outer layers you are looking at that are risk factor are not there. So we have a clean population, and that is not the case with renal failure patient. So those equations, what the researchers did, rather than to use the creatinine, derive from the creatinine a better indicator, since the creatinine of 1.5 may be normal renal function or may advanced renal failure. Let's modify this creatinine by including in the equation risk factors, or factors, not really risk factors, but factors that make that a normal creatinine means different things depending on the person, the size of the person, the gender, the race, and so on. And those are these multiple linear regression stepwise that were done to derive those equations from the MDRD study. Here, for example, Andrew Levy, about 20 years ago, started to develop those equations. For example, here I have equation number 6, equation number 7, if you see my arrow. And by adding different parameters from the database, you can improve the fit, and you aim to get a very good correlation between the GFR and the glofil or iothalamate clearance obtained for those patients. So that you can now use a predictor of GFR based on creatinine by modifying and obtaining equations. But still, I want to point out, you still have quite a distribution. If you take a patient with a GFR of 40, his GFR may as well be 60 or 15 because of this spread. So at the end of the year, when you apply this, you are always good because you have a reduction to the mean. But if you take individual patient, you may still be thrown off by this kind of analysis. So keep in mind there's always possibility that you actually deal with renal failure when the creatinine is normal. But at least this equation or those equations take care of, for example, this difference. You have a patient, an elderly patient with a creatinine of 1.2, the same creatinine in a middle-aged person or in a young athletic person mean totally different GFRs. This patient has significant renal failure. This one has already some renal failure, CKD2, and this one, the young person with a creatinine of 1.2, may have a normal GFR, no kidney function, assuming there is no structural abnormality in the kidney. So keep this in mind. Here is a study that was published about 10 years ago, looking at a big cohort of about 4,000 patients who donated kidney. Remember, those are patients selected for nephrectomy, the donors, the living donors. And you can see that the overall survival of this population compared to control is totally normal. There is no adverse effect of taking a kidney out. But again, this is a population that has been chosen for absence of risk factor, not like in the patient we deal with. Here, related to this, I have a question. A patient with a stable baseline creatinine of 1 had a radical nephrectomy, and then later on, the tumor was 7 centimeters, and it was localized. And then later on, he had a creatinine of 1.9. The operative report is concise, and both the gross and microscopic, in other words, the type of tumor he had, and we know what type of stage in the cancer he had is there. And we have also other information about intraoperative blood pressure, blood loss, and so on. Now, to explain this creatinine of 1.9 or to understand it, what else would you like to know about this patient? Is it whether the tumor was large with the histology and so on, the normal tissue of the patient and so on? So the question, most of you probably will agree, you want to know the pathologist's description of the normal renal parenchyma. I say normal, or how abnormal was it at that time, so that we can do projection in the future. And this is very important, as you're going to see in the next slides. So here, the first study, I'm starting again with Andrew Levy, who developed those equations. He wanted to show how useful they are, and he worked with a urologist. They had about 600 patients selected. They had small tumors versus, small tumor, and they had radical versus partial nephrectomy, and they are looking at the outcome concerning GFR. They selected patient with GFR of more than 60 as a cutoff for renal failure. And you notice that of this patient with GFR that were normal for their morphologic presentation, 26% of those patients already had GFR less than 60. So you see, we are dealing with a different population. So we have to be aware of that. And this is very, very important. Looking at the follow-up on those patients, those with partial nephrectomy as compared to those with radical nephrectomy, those with partial nephrectomy were free from risk of having new onset renal failure at, for example, at 3 years. At 3 years, they were 80% free versus those who had partial nephrectomy had much less free from going into a renal failure probability. And this difference is significant. If you look at more advanced renal failure instead of 60 less than 45, again, you see, for example, at 3 years, those who had partial nephrectomy fared much better than those who had radical nephrectomy in terms of free from reaching renal failure after surgery. So this landmark study has made the physician aware that you should do, as if possible, partial nephrectomy, because the outcome in terms of renal failure is much better. I don't want to advocate that we do real 24-hour creatinine, because that itself has a problem. If you want to do a good clearance, you have really to make sure the patient gets a total collection. So I'm not advocating to do actual GFR, but at least aim for partial nephrectomy instead of total radical nephrectomy. Another study from Korea looked at renal cells. They did radical nephrectomy and looked at the outcome, and they divided the tumor size into small tumor, middle-sized tumor, and a little larger tumor. And they found a correlation, inverse correlation. The larger the tumor, the lower the GFR. Okay, and they claimed that patient with a smaller tumor size developed more CKD after a radical nephrectomy. And we are going to look at the follow-up on those patients. So here you have pre-nephrectomy, 1 month pre-nephrectomy. Here you have about 7 days post-nephrectomy. Here you have 3 months and 1 year. They follow them for more than 3 years. As you can see, patient with good GFR actually, the one with small tumor had more loss of renal function than the patient with larger tumor. They had less fall in GFR, which seems paradoxical, but we saw that in different studies. It's not the only study that shows that. So the delta GFR was in patient with smaller tumor was 28, whereas the delta in patient with large tumor was only 18 milliliter per minute per 1.73 square meter, which is kind of an unexpected finding. They looked at the predictors, and the predictors of fall in GFR, older age, diabetes, hypertension, and low GFR to start with, and high uric acid. And what they found is patients with small tumor had a 2.3-fold difference in as compared to patient, the higher risk for new onset renal failure as compared to patient with large tumor. Same patient with intermediate sized tumor had a 2.24-fold higher risk of acquiring renal failure as compared to patient with larger tumor, again suggesting some kind of a renal protective effect of tumor size in terms of how they feel after the nephrectomy. This apparent paradox has stimulated research, and there's here, for example, an Australian group that looked at what would explain, they think it's a paradox. I don't know if it's a paradox or not, but they tried to find factors that could explain this paradox. They looked at age. They were claiming that age and tumor size were associated and things like that. And also that there was a selection bias. I wasn't too much convinced by this study. But let's look at the scheme. We have a small tumor here and a large tumor here. The question is, what happens if you do, for example, radical nephrectomy here or here? Obviously, here you are going to take out much more healthy tissue than here. Whether this volume is smaller in patient with large tumor or not, or whether this tissue is less healthy than this, is hard to say, but that's why it's important to know the state of the parenchyma in terms of volume and how healthy that parenchyma is to make predictions. But we need to keep this in mind. Another study from Sloan Kettering looking at about 500 some patients, and they dichotomized them into patient a little bit a la Levy, in patient with a GFR above 60 and in patient with GFR below 60. And they followed their creatinine post-surgery. And as you can see, patient with better GFR had a progressive decline post-op to about 8 months and then regained their pre-GFR value, whereas the patient with lower GFR to start with, they didn't have a fall, but had a progressive increase over time. So again, this is a little paradoxic, but not if you look at what predicts the recovery. Here is the cumulative result of this study. The dotted line are patient with smaller GFR, and a solid line are patient with better GFR. And as you can see, with time, the one with lower GFR actually recover renal function more than the others. For example, by 3 years, there is a 58% recovery in patient with lower GFR as compared to patient with larger GFR. So it's always not intuitive, the data we obtain, and we need to take this into account. Here the predictors, remember they dichotomized them in patient with low GFR and patient with better GFR. The predictor of how they will do are different in the two groups. For example, in the patient with good GFR, the predictors are hypertension or tumor size. This one has a negative predictive value. This one has a positive. And a patient with lower GFR, age and gender is more important. So you deal with different population. So it makes it very complex to do predictions in those patients. Here we are back with the Korean study. This is the same group, about six authors on the article are the same as the previous study I had shown you. This study looked at what the renal volume is after nephrectomy. They looked at the functional renal volume in patients with radical nephrectomy. And as you can see, the GFR again falls after nephrectomy here by 31%, here by 26%, and here by about 12% according to GFR stage. So again, patients with good GFR have a more decline in renal function. But when you look at the functional renal volume of the kidney, of the remnant kidney, the functional renal volume being the healthy tissue as obtained by CT, looking at enhancement in the venous phase that allows you to measure and quantitate the renal tissue. As you see here from the renal kidney, you have about 200. The total is about over 300 volume if you measure both kidneys. And you see all the groups recover healthy tissue, functional tissue like they call, but there's no difference in recovery. There's a difference in loss. The one with better GFR lose more, but all three groups recover the same. But when you look at the ratio of GFR to functional renal volume at that ratio, you see they all increase. But the one with the lowest GFR have the highest increase in the ratio of functional renal GFR over functional renal volume. And that is basically a marker of hyperfiltration. Here the predictors again were body mass index, diabetes, hypertension, the value of the kidney, the GFR before, and the pre-op functional renal volume, which they included here as well. More recent studies we are looking at, and I'm going to go fast. This is a recent study comparing the outcome. They had about close to 60 total review, like a meta-analysis of articles, which shows essentially that partial nephrectomy over radical nephrectomy favors partial nephrectomy. If you compared radical nephrectomy with temperature ablation, somewhere it's written what is what. Temperature ablation is better, just like partial nephrectomy, when there is no difference between temperature ablation and partial nephrectomy. So again, the alternative mode to radical nephrectomy favor again partial nephrectomy. This publication came since our presentation as well. This was the only prospective study quite a while ago. It was underpowered, unfortunately. All the studies we saw up to now were retrospective studies. The only prospective randomized trial, unfortunately, this was in Europe, like the Babel Tower. Many countries participated, but they couldn't get a total pool of 1,300 patients. They only got 42%. So it was kind of underpowered. And recently it was reviewed by the Cochrane review. They looked at what happens post-nephrectomy, and they only could find one study, and that is this one. And they analyze as if those who have looked at Cochrane studies, they really slice and dice the study and so on, and they concluded that it is not enough powered to make predictions in which one is better, partial or radical nephrectomy in terms of outcome. tumor outcome is the same, so there is no reason not to do. Now let's see what's on the radar coming. We kind of invoked single nephron GFR when we talk about GFR divided by healthy renal tissue, right? This kind of suggests the concept of single nephron GFR. In other words, concept of micropuncture. The filtration fraction, GFR, divided by effective renal plasma flow invokes data from the clearance literature, but we need to revive those kind of parameters to be able, and that's what we see happening. We see people trying to find the functional degree of hyperfiltration and so on in patients. For example, a recent study, or not too recent, but recent, since I did the presentation in the New England, Glassock was involved in that study. They looked at donors and they looked at single nephron GFR since they had the ability, knowing the total GFR, the histology of the biopsy and so on. And they calculated the single nephron GFR, and this is the same, even though the standard deviation, because the crude method, is large. But the New England Journal found this of enough interest to publish it in their journal, because it has important implication. Looking down, what is in the future, there's a review from our colleague from Gainesville. Artificial intelligence is going to affect nephrology like many other fields in terms of diagnostic and prognostication, by looking at combining data from all sorts of data and then tweaking this data into artificial learning, artificial intelligence, and so on, to give us output, as you're going to see here. For example, deep learning based on histopathologic, you can digitalize the biopsy and then have the computer do the artificial intelligence due to convolutional neural network, CNN, come up with the diagnosis. So you actually don't need an observer, a pathologist. Essentially, in the future, you will have digitalization and you will have a diagnosis given to you. Same with when we look at an ultrasound. This is this study was from the Netherlands. This study here is from China. If you look at an ultrasound, you always look for the radiologist telling you whether the cortex is dense or not, cortical echogenicity, to give you an idea of medical renal disease. But the eye is not trained to say more than that. But using computers, you may, and it looks like it's feasible, you can predict the degree of GFR just looking at the cortical echogenicity. So this is something to keep in mind. And again, using digitalization of images. Here you have a CT with contrast with a small tumor, and if you can recreate the renal parenchyma and do prediction based on that. And as you can see, for example, you get post-op GFR versus pre-op. You get a good correlation. The problem with this is they should have done Deming or passing Bablock type regression, not linear, because remember this, there is variability here as well as here. So you have variability in both. To generate this data, they should perhaps use the MDRD equation, but they should measure actual measure of GFR. I think I'm done with my talk. So if you have any question, please let me know. Thank you.